Thank you very much. We have time about 10 minutes for some questions. I'd like to also start out just asking the folks up here who are largely investigators, if, listening to what you've heard today, you had one sort of research type question that you could get answered to better get a handle on disparities, healthcare disparities for existing technologies, as opposed to sort of pushing the envelope with new technologies, what would that question that you want to have answered be? Few questions, but I think we should come back to that because I think it's a really helpful way to get sort of some next steps ideas for the next session.
Hi, thank you to this panel. And I actually didn't put my glasses on, so I read Exploring Innovative Solutions and Models of Access, which in fact is much more relevant to the question that I was going to ask. I'm Glen Darien from the Patient Advocate Foundation, but in this context, I'm wearing my hat as chair of the Community Engagement and Genomics Working Group of the NHGRI. And so one of the things that I didn't hear in this, and I'm not sure, and so I'm just, it's a question, not a challenge, is in our working group, we spent time certainly talking about what genetics and genomics are and thinking about how to communicate that out into communities. But we spend an equal amount of time trying to think about what the barriers are to and what the community's perceptions of benefits and harms are. And so it doesn't surprise me if that is not being addressed in some of these questions, that the uptake of genetic testing may not be as high as you would have expected post genetic counseling if those kinds of questions are not addressed. So I think that we're going a little far down the road before we understand what some of the group harms and benefits and community beliefs are. And I will also say, just to add in, I've been we just had a meeting where one of our members who was from a group of healthcare researchers, health services researchers who are LBGQ. I was shocked at the fear of genetic screening in his cohort and his group, whereas I wouldn't have been as shocked in our members who are American Indian. So. Did you ask those questions? Was that part of the counseling? Or did you just go right to assuming that what people wanted to know was what genetics were, what screening was, what testing was, and what it could do in terms of determining care?
I can answer that for our studies. So the studies we presented were clinical populations, and so and we were purposefully trying to use as the basis for our genetic counseling the sort of traditional genetic counseling model and tweaking it in the ways that we did. And so the answer to your question is no, we didn't do that in those studies, but we are certainly doing that as we develop interventions in more community-based studies.
Can you just simplify your question, because I got lost a little bit?
Sorry.
I'd like to try to answer.
Sorry, I think one of the things that I was thinking about as I was listening to this is that if you go directly to, in genetic counseling, the explanation of what genetics, genomics are and their clinical application, without understanding the underlying beliefs of and the fears of harms and benefits of the populations you're trying to reach and the populations you're trying to get to increase their participation, that you're missing you're going too far forward before you understand the fundamentals. Is that clearer? Yeah.
I think so. A couple parts that I might put in there. I think the harms, I think, could be two different parts. Right? There could be the financial harms to the system, as well as the the fear and anxiety and some of that sort of stuff. So I think the first part of it, the financial part, I think clearly needs to be, there should be some studies to actually do that. And as I mentioned, there's precious few cost utility analyses on any of these things, and getting economists, health economists together with geneticists. So we have, as part of our study, we have a card-carrying health economist on there, and there's been a lot of, back and forth about, her trying to understand what the difference is between SNPs and SIPs and, CNVs, all these things that we use, as well as us trying to understand all the 47 different types of cost and charge analyses and stuff they have to get that communication so everybody understands what everybody's talking about. So I think we need, number one, a lot more of those. The other thing, and it reminded me of some discussions we had within the bioethics folks over the last few weeks where, and I haven't read this literature, but I just throw it out. Maybe other people can comment on it. But they said typically the anxiety and stuff like that is a very short. There is some initially, some anxiety and harm like that, but it's a very short-term thing, and it typically after a few weeks, actually, from what they were saying, goes back to the normal baseline anxiety, things like that. So I think that's something that needs to be really fleshed out and explored more. I'm not an expert on it. That was just sort of my takeaway from what they were.
I will say that that's part of our training that we're doing to retrain genetic counselors. In our first study, we used standard procedure genetic counseling, but based on the ethnographic study that I told you about, we have made changes, and in our current study that's still ongoing, we are using our training, first of all, so that the genetic counselors are on the same wavelength, and the only difference that we'll be looking at is the difference between in-person, telephone, and video. But we have trained them first on these communication strategies, and we're getting a high uptake of testing. So far we've had 98 people offered testing and 84 have been tested. And that doesn't, I don't know how many are still in progress. So, we have a long way to go to fully understand what these changes in training are doing, but I'm pretty certain we're going to see, that the counselors are addressing more of what the patient really wants to know, because that was just way off in the earlier study.
Great. Thank you.
So I'm going to ask this to be a lightning round of questions. I've got permission for 5 more minutes, but quick questions, quick answers, please.
Hi, Latrice Landry, Harvard Medical School. So I know we're not talking about underrepresentation in genetic research, but Dr. Scar opened the door when he said the right dose for the right patient at the initial visit may improve care for underserved populations. And I specifically want to highlight the research in CYP2C9, which shows that dosing algorithms for warfarin may not dose African American population specifically because there were variants that were not captured because they're higher frequency in those populations. They weren't captured because those populations weren't included or were underrepresented in the initial research. And the question is, how do we detangle the clinical use or access to genetic tests from the lack of evidence of clinical utility in diverse populations? How do we detangle access from lack of representation in research? Thank you.
I think the best thing is we need we need to include, have those studies done in all the populations, because I don't know that you ever can, if you don't have patients in with those variants and then you try and apply variants from a different population to that, there's just no way to do that, I don't think. So I think we need to include, a broad populations in those studies. I think, is that, well, yeah, no, I totally agree, and that was a very important finding on that study.
Joan Scott Hersa. I'm not sure if Katrina is still here, but I'm going to channel her, and this may be an unfair question for you because you come from the research perspective, and so you're looking at this with very, formalized methodology.
and adding to the general knowledge. But she made this statement that if we really believe something should be done, this should be moving into quality improvement, where you're looking at something, we know something should be happening in a very specific setting, and so you unpack what may be happening in that setting and using rapid change sort of cycles to see if you can get it to improve. So I just wonder if you could comment about how we should be approaching this, particularly for those applications where we really think should be moving into clinical practice.
I think it's a great idea.
Oh, Katrina is here. So, yeah, so what? Are you agree?
I would say, I don't know that we have ARC in the room, but we probably have other funders. And so one of the obvious ways to do that is to think about how we cross-fund between efforts focused on quality and improving quality and efforts focused on genomics. And I think for this group, I mean, I've lived as a researcher. If you put out an RFA, it's remarkable what happens.
So next.
My name is Megan Raymond, and I'm a medical student at the University of Pittsburgh. I was wondering what me and the next generation of physician providers can do to incorporate genomics into our training, especially in an already crowded curriculum.
Well, I think that you're already doing it. You're taking part in workshops like this. You're coming to hear speakers on various topics in genomics. I think not only taking classes at your university, but seeking out other opportunities to learn about genetics and genomics, whether it's through your professional organizations, but also through other opportunities like this one here.
I mean, practical training. I mean, we have a fellowship, T32 fellowship for fellows that, and a large part of what they do is spend time thinking about and working on pharmacogenomics implementation type studies. Getting real world into actually evaluating patients and gene drug interactions for pharmacogenetics, I think is the best way to actually do it. You can read about it a lot, but until you actually see it in real patients that have 47 other concurrent medications and 12 other diseases and all this stuff, that's when you really, learn a lot about it.
So one more question. I think that could be a whole conference, by the way. So
yeah, it has been, hasn't it? Yeah, several. Kathy Wicklund, Northwestern University, and I feel compelled to get up and give Rena some hope for genetic counselors. I am a director of a graduate program in genetic counseling, and it's interesting. I mean, I hear everything you're saying and spend so much of my time actually trying to, I have 2 students in the audience, beat the notion out of them. I don't physically beat them, right guys? No. That they have to explain everything about a gene. So we're trying really hard to change that perception of what genetic counseling is and the idea that you have to go in and explain, and it doesn't matter if it's underrepresented, it's the person sitting in front of you and what they need to know at that particular time, and how do we assess that, and how do we figure that, and how do we, assess their comprehension. So I want to assure you that there are programs, and I think that are really trying to embrace this so that you're not retraining genetic counselors once they're out. But I think it's something that we as a profession really need to think about, this perception of what we do is just convey huge amounts of information and provide information dumps without any kind of assessment of what that person actually wants and where they're at across from you. And also the relic of non-directiveness, which is a relic of our profession, and that we have to do a better job at balancing the idea that, no, we're not going to tell somebody to have an abortion, which is, but we are going to help guide you in thinking about testing and provide more guidance than just a very passive role in decision making. So I just wanted to give you some hope, because I sense hopelessness.
Actually, thank you very much for that. That was great. But I also spoke to someone recently, a new graduate from Hopkins, and she said similar things. So I am becoming optimistic about the field. But we're also working with the Genetic Counseling Association.
Yes.
And so I think together these things will change the field. But don't be so sure about abortion. Anthony Kennedy is retiring.
So, very quickly, unfortunately, no more questions. The thing I asked you for. Want to start at the end? Single research question that you think would really be very helpful to understand disparities.
I guess a single question would be how does the implementation of genomic medicine differ when it's done in pragmatic trials that include a diverse population or a broad diversity of populations?
I think the one question that I would pose to people would be, how can genomic testing help you or be beneficial to you? And I think it gets to the comment that Janet Williams made earlier today, is that we really need to listen to people in the community. Sometimes as providers, we do a lot of talking, but we need to listen to find out what it is that people really want and what they feel that they need, and provide those services.
I guess I'm going to push back against the simplicity of the question, because I
Expected that fully from all of you, because I think, the scientific end of the community tends to be reductionist in its thinking. What SNP explains what outcome, whereas this community tends to be, this is very complex. But we do need to get to sort of next steps. So I would ask that you try to distill, if you have 10 in your head, what one do you think would be of highest priority?
I can't.
I don't know. I guess for me, for genetic tests that have demonstrated clear clinical utility, how can we identify individuals in a routinized way in order to ensure that they are getting referred, and then how can we support that sort of step from being referred to actually obtaining whatever the genetic service is, whether it's traditional counseling or some other form of service. How can we make sure that that's happening for those tests that have clear utility?
Might have been 3 questions, but that's okay. Okay, with that, I'd like to thank all of the speakers, and we'll move into the last session.